The terminology knobology was used for echocardiography mainly because this terminology came up because in the earlier echo machines there were big knobs used to control and change various functions. So initially it looked very confusing to the beginner as to what these knobs do, what will happen if you turn it on or increase it or decrease it. So knowing what are the functions of each and every knob is the topic for today. So if you have a car, if you want to ride in very smoothly, you have to have the best out of your car. You need to know what the manufacturer had put in into the car with all the switches and knobs in it. And if you don't know how to use it, maybe you are paying for a big costly car and you are not able to utilize that functions to the maximum. So the objective is to optimize, learn the manufacturer techniques so that you get the best possible contrast for your echo image. I have used various references, mainly from Feigenbaum Auto, and I had studied the user manual of the portable echo machine which we use in our hospital, and also have referred the ASC guidelines, 2019 guidelines for echocardiography, and they have given few pages about optimizing the echo images in their guideline. So in this more lecture, we'll cover all these, the various echo modes, the transducer, and how do they work, and how the various types of arrays when we use in a transducer, what are the probe movements, then how to optimize the echo in each and every mode. Like 2D echo, there are all these functions which you can optimize. And when it comes to Doppler, various parameters are there which you can optimize to get the best Doppler signal. Color Doppler also various parameters so that you can get the best color image, and the M mode also various optimization techniques. So echo machine manufacturers, there are various manufacturers. In our hospital, we use mainly the GE machines, and in our ED we have the Sonosite. Other machines are also work on the similar optimization techniques. All these, the lecture which I'm going to give will work for almost all these manufacturers, but there'll be a slight change in the terminologies. This is the echo machine which we use in our CCU. It's a GE called Vivid E. So this is the front panel, and I'll be discussing each and every knob what stands for, how we can optimize it for this thing. So this is the front main screen for the echo machine, and we'll just explain what are the this thing. This is the logo of this thing. This will be the patient name will come here, and as well as the hospital name also can come here. Then this is the date and time at which the echo examination was performed, and this is the probe name. 7SRS is the probe name. So in our typical cardiac echo, it will be like it will be called P21, etc. Because P stands for phased array. Cardiac probe is a phased transducer, and if it is cardiac, adult cardiac, and all that will come here. MI is a mechanical index, and the TIS is a thermal index, and S stands for soft tissue. So mechanical index and thermal index will come in detail later. It generally stands for a parameter, a value for which how much of these ultrasonic waves can cause damage to the tissue. That is mechanical deformation of the tissue, a value, and thermal, how much the ultrasonic waves can heat up the tissue. And this is the current live date and time, and this shows the heart rate. If you are connecting the ECG, it will show the heart rate. And this is the parameter window which will show the current active scan parameter. So here we have the frequency which is displayed here, and 3.5 is the current active frequency, and it shows that it can go up to 6.9 megahertz. PROC stands for processing. Actually, it is a DDP parameter which we'll discuss later. This is a big complex number which we generally have no purpose. We generally do not use it. Power stands for the power in decibel for the ultrasonic sounds which the manufacturer which actively it's going on. So there is a limit to the power. So whether it shows that whether we are using the maximum power of this. So this setting can be adjusted here in the soft menu. This is the parameter window, and this is the soft menu. So various parameters which are coming up here can be changed here. with a soft menu. So we have some 4 button rocker button below here. Hard keys are there which we can control this. So FPS is a frame per second. That is, it shows the resolution and all. Depth is the how much depth the tissue is being examined. So here the depth is around 7 centimeter. And because this is a color flow image, we'll see the parameters of the color as well. So gain is the color gain actually shown here. There is separate gain for the 2D, and color gain is minus 20 decibels here. Scale, we can control the velocity scale of the color Doppler, and that when we change it, the value changes here. The frequency, then SV is a sample volume, so 0.8 millimeter. That is, there will be a sample volume marker here when we just put the pulse Doppler and all. So that is pointed up to 2 to 4 is the usual sample volume. Ideal to keep it as low as possible. LV is the low velocity rejection. It will reject the low velocity echo signals and all. Then this is the soft menu window, various parameters which we'll discuss. DDP, this DDP when you are adjusting only, it will come as a processing here. The DDP is, I'll come into detail about that later. Sample volume, we can set the size here. Here, this is kept at 0.8. Frequency, lateral average, radial average depends on the radial and this thing, resolution setting and all. So this is the current cine progress bar actually. Whenever we keep a prog, it will start the recording automatically, and when we press the store button only, that particular cine image will be saved. So yeah, here it will the maximum limit which we preset it before is 93.9 seconds, and now it is playing at 3.8 second of that. This is the total length. This is the current time, and this shows the frame. That is total of 4,540 frames are there in this video, and we are currently at 184th frame. So frame by frame we can access here. Here various parameters, power, all these things will come into detail. Scale, velocity scale. Inverting is like we can invert this upside down, and all various color maps we can choose. Variance is another parameter. Frequency variance, this will come in detail simultaneous. So when this then baseline comes in color Doppler, we can change this baseline here. Below this we have a round rotating knob, which this thing can be moved up or down. Frame rate, everything can be set here. So this is just a brief thing. On this left banner, we have the measured parameters, which we have got it after making this thing. This I hope everybody knows: interventricular septal, IVS in systole, internal diameter in systole, posterior wall systole, etc., etc. This is the ECG this thing, and various clips which I have said comes here. Here the settings come. We can change various parameters, which we have to take the mouse and click here. We'll get various parameters here. The network will be displayed here. The power and the battery status will be displayed here. So this is a brief introduction of the Echo monitor window, how it appears, and we'll go into detail later. So there is a general rule for doing echo, that is we have to use jelly to the maximum. That is, more the jelly, the better. Pressure, you have to apply adequate enough pressure so that until the patient says feels the pain, you have to press. So the more you press, the more the better image you get. But don't give more pain, but a moderate amount of pressure is always required. If you use less pressure, the less quality of the image you'll get. Then to attain the window initially, it is suggested that you go in a circular pattern to find the best views. That is, you have to search in circles rather than going tilting or sweeping or something. You can go with the probe initially to get the best window initially. You can go in a circular manner, and the left lateral decubitus position is ideal because it will bring the heart more towards the chest wall, and you can get a better listing. The depth will be reduced. So in females, yeah, you will have the issue of breast tissue interference there. There also make sure that you have to press hard. So some echo languages, you have to know what is hyperechoic, hypoechoic, and anechoic. Hyperechoic means that if the surrounding tissue is more bright than this thing, then it says we can say it is hyperechoic. That is, it's more echogenic than the surrounding tissue. If it is less echogenic, it will more appear more darker than the surrounding. It is hypoechoic. And if it is devoid of any echoes, it will appear totally black, and that is anechoic. That is, there is no echo happening there. Then coming to the various modes in echo, we have the A mode. A stands for amplitude, and B mode. B stands for brightness. M mode. M stands for motion. And then we have the various 2D echo, 2D mode, 3D mode, as well as a 4D mode. So these are the various pictures showing various modes. So A mode we generally don't use that much. This is how the A mode will be shown in this thing. And the B mode is the brightness mode, and M mode is the mode which is a high resolution mode, which B mode is the normal 2D mode actually. M mode is the high resolution mode, which we will come in that later. High resolution, see the values, etc. So this is how the M mode looks like. And so difference between 2D image and the 3D image. A mode, this is how the A mode appears. It is shown as amplitudes. Comparing to the M mode, this is how M mode looks like. And this is how the 2D or the 3D image looks like. 2D, 3D is actually 2D itself, but we take more uh, slices with the 2D, then we attain a 3D image. That is how we obtain a 3D image. So now coming into the transducer, that is, this is the typical cardiac transducer which we use when we saw how an ultrasound works, or the echo machine works is current when we pass through a piezoelectric crystal. That crystal, because of that current passing, the crystal will vibrate and it will generate ultrasound waves. So these waves will be passed through the chest wall and it will be going into the tissue, and when it goes into the heart and into the myocardium, when it strikes the heart, it will be reflected back. And this reflected sound wave will be picked up by the transducer itself, and then which will be transformed into the image, transformed as images. The transformation which we call as a fast Fourier transformation, which is a very complicated procedure, the details of which we don't go into now. So it will generate an electrical impulse when it is deformed by the reflected sound waves. That is, the reflected sound waves will generate an electrical impulse, and this electrical impulse is converted into image. So when we talk about the transducer, the lower the frequency of the transducer, generally the more deeper the sound waves can go into the tissue, more penetration. So our acoustic range is 20 hertz to 20 kilohertz. So about 20 to up to this thing is the ultrasound this thing. And this is out of curiosity and interest I had I'm showing a video of what is there inside echo transducer probe. So this is not a cardiac transducer probe. This is a curved probe which we use for abdominal examinations, but fairly all are same. So in this video, this is a tear down video of cardiac ultrasound probe. So So inside that, actually, there is the piezoelectric crystal is not sitting here. Actually, all these are micro circuits. That is long wire that is going. Actually, the piezoelectric crystal is situated exactly here at this curvature. It is at the tip. It is not inside, so it is very much exposed. And we have to think actually a large piezoelectric crystal is cut down into very small pieces and fixtures. So these are the electrical wires or the circuits that connect. So this current is passed through this electric cell. So at this point, there are small linear sequential piezoelectric crystals, and each of these crystals are connected by a electrical circuit is connected at the top and the bottom. So the current passes through these crystals, through these microcrystals, and this is a sequential probe, linear sequential probe. So the connections are at the top, and this what you see here is the piezoelectric crystals which are arranged. So this is a very delicate. So when you drop it, this phase very much exposed. If it falls on the ground and if it hits this part, these piezoelectric crystals will be damaged, and you will end up damaging your probe. And be careful. So, and mind you, the probes are very costly. So be careful when handling with probes and not to drop it. So we come to the probe more. There are various types of probes are there, and we call them as the arrays, and that is the mechanism by which these probes act. So generally they are divided into linear as well as the curved probes. Linear, and they are again classified as sequential as well as phased. So linear probes are the wide probes generally we see, and the sequential array, linear sequential array and the linear phased array. So in sequential array, what happens is each of these piezoelectric crystals are fired sequentially in the sequential array. In a phased array, that is, this is the typical which we have to concentrate more because our cardiac probe is a phased array probe. That is, it is fired simultaneously but in phases. That is, in multiple phases, it will be firing simultaneously. All these things are phased changes. So the advantage is we can steer and focus. The details of which will come later. So the other probe is the curved probe. You typically use for the abdominal examination and all. And there is an annular array, the third type. I suppose this is used for the 4D imaging and all. And speaking of the IVUS, the intravascular ultrasound which we use during intervention, IVUS can use either a single probe, and that probe, the single piezoelectric crystal, and that crystal will be made to rotate with the motor. So that's mechanical rotated, and the crystal itself will turn this thing. Or the IVUS can also have a phased array at this stage. So what we have to focus is that we have to consider that our cardiac probe is a linear phased array probe. So this is a linear probe, this is a curved probe. So linear, this is how linear, like all these are fired linear sequential probe. And linear also comes as linear phased. So this is our phased array transducer, curved, and so these are the various probes. This is our cardiac probe. P stands for phased. P21 is that model. So this probe number will come in the echo machine we are doing. L for linear. This is a linear probe. Use a vascular and not vascular. This thing. This is the curved probe, and this is C. So all these linear probes will be minimum of around, will be wide and minimum of 4 centimeter and all. So that's it. So we have to notice that our cardiac probe is a low frequency probe. 1 to 5 megahertz is a typical thing, and the others are all high frequencies. Why? Because for doing a cardiac echo, we need more deeper penetration. That is why we generally use a lower frequency probe. Same which I told. So how does a phased array transducer work like? Work is like phase here. This is beam steering, and this is beam focusing. So how does it do that? These are fired here when this will be fired first, then after a lag of time this will be fired. It will be fired like that sequentially, so that wavefront of that will be steered. That is, it is not straight, so it is straight. This is the final wavefront, so it will, in this way we can steer it. It's typically useful when the steering is usually used in a mode where we can steer this. So in our echo machines now we have a button called steer and all, which we can change that setting. And how does the phased array probe focus it as? This is how they turn it on by after a limited number of time, and thereby they focus the image on a center. So that is how they do it. Just the basics of the physics, the details of this we need not know much. So cardiac probe, curved probe, and linear probe. So cardiac probe typically up from 6 centimeter to up to 35 centimeter depth we can go, whereas the linear probe can go only up to, for vascular can go up to 6 centimeter and up. So the general rule is lower the frequency, more the penetration. But your resolution, you have to compromise on the resolution. Your resolution will be less. So this is the one that applies to our cardiac probe. We have a low frequency probe with more penetration but less resolution. But still we get the acceptable level of resolution. And this is our typical cardiac probe. It's a phase array probe. It has a small footprint. This is what we call as a footprint, the face of that. And this is where the piezoelectric crystals lie. And it is best for structures deeper than 6 centimeter up to 35 centimeter. It has a low definition but high penetration. Low definition means the resolution is low but more penetrate, and the typical range is 3 to 5 megahertz. In short, for megahertz we say 3s to 5s. So we have to apply jelly when we are doing an examination. Why? Because these ultrasound waves have different velocity in various mediums. So as from this table we can see that in air it has a very least velocity. So there is air intermediating between the probe and the patient's chest wall. So that air is a poor transmitter of sound. So you should put some medium in between so that it will transfer. So when you put the jelly, the velocity increases, maybe somewhere to 1500 or 2000 based on the jelly we use. So the echo jelly will increase the velocity and the transmission of sound will be improved. So mind you, this is not the jelly that we apply. This is a jelly that we have put it. So the question is whether we can use a ECG jelly for doing echo. I'm not sure about that, but generally, if you are filling that space with anything other than air, maybe that will work. And ECG jelly we apply, and we are trying to get more receive the electric signals from the heart. So this is ECG jelly we are dealing with electricity, whereas in echo we are dealing with sound waves. So there may be some difference in the jelly, but most of the time we may not. We may, when we're doing an echo jelly may be empty, but we may have an ECG jelly at hand, so we may tend to use that. So in pediatric patients, they have a thin chest wall, so you need not have too much penetration. So a more higher frequency probe you can use in pediatric patients. So thin chest wall. So typically they require a high frequency probe actually. If you don't have a pediatric probe and you are forced to do an echo on a pediatric patient with a adult probe, then you use the highest possible frequency, that is up to 4.55. You can put in the echo, change the frequency to higher for that available adult probe you have with you, and then you can do on pediatric patients. So typical frequency required is 9 megahertz, or adult is up to 5 megahertz. But in this situation, we can try, but still the image may not be that good. How to hold the probe? There are two ways. You have to hold it under the probe or over the probe. Under the probe, this is the most commonly for most of the views. You have to use under the probe. That is, you have to hold the probe like a pen, like this, like a pencil or pen. And for over the probe, you use it like this. That is typically used for a subcostal view and all. That is over the probe. That is hand under the probe or hand over the probe. That is we mean by under the probe or over the probe. So probe movements. These are the various planes. That is in the x-axis it can go like this, and you can rock it like that, or it can go in all the planes. In the y-axis it can go anterior and posterior, and it can rock. You can rock it left or right, and on the z-axis you can go press it or compress, go down. So these are the various movements, and you can rotate the probe. So the typical uh, terminologies for the probes is one is sliding. This is how we do a sliding. The other is compression, or otherwise called stabbing or compressing. That is, we press hard. Typically not used in cardiac, but used for vascular when we are assessing vascular structures, like looking for an artery vein with a linear probe. So we get differential compressibility of artery and vein. Based on that, we can, and as well as the nerve also. So that is compression. Other is rocking. That is how we do rocking and rotation and tilting. Tilting is otherwise called as fanning. That is, you angulate, otherwise called angulating or fanning or tilting. So in the next slide, we'll go into, so these are the various movements of the probe, that is sliding, or otherwise called as translate. Rotation, you know what rotation is. Then tilting, otherwise called as fanning, sweeping, angulating, all means the same thing. Rocking, or otherwise called heel toeing. Compressing, or otherwise called stabbing. So these are the important probe movements. So our 2019 AAC guideline gives all these movements in a table form. However, these terminologies were not there. I have included all these terminologies also. These are the various other terms which we can use. That is for tilting, fanning, sweeping, angulating, all means the same thing. So coming to the concept of near field and far field. So when we keep a probe on the patient's chest wall, there is a near field, and after which the ultrasound beams go, and after which it will diverge. The beams will diverge. So that from the point of divergence, that is the far field, and this where it is straight and thing is the near field. So image is very optimal when we scan in the near field. So the ideal is you have to get maximum length of this near field. That is better. Smaller length is not that good. So the length of the near field will depend on the radius of this probe, as well as the wavelength or the frequency of the ultrasound wave which we are giving. So optimally, a larger radius and higher frequency is better. This concept you'll understand in the next slide. Here, suppose we have a radius of 10 millimeter and the frequency of that probe is 2 megahertz. You are getting a near field of this much length. Now, if you increase the frequency of 2 to 4, you are getting more increased length of the near field. So this is better. Now, if we reduce the probe diameter to 5 mm and keep it at 4, you are getting a lower near field length. Similarly, when you are decreasing the frequency further, you are getting much lower. So this is a very optimum. That is, getting the maximum length of the near field is much better. That is, the waves will diverge only after sufficient length. So now coming to the concept of what are the interactions that are happening when the ultrasound beam reaches and touches these tissues, our cardiac tissues. So these are the four possibilities that can happen when these ultrasound beams are transmitted. It can hit the tissue, and it will it based on the echogenicity of the tissue, it can reflect the sound waves back into the transducer, and this is how this reflection is and this reflected sound wave will be accepted or received by the transducer, and it will be that electrical impulse will be converted into image, and this is the basis of ultras echo working. But not all the sound waves which you send to a tissue gets reflected back. There will be a part of the sound waves will go refract, that is, it will change its course and go to a different direction, and then further it will attenuate, or it will take the straight path and it will attenuate after coming later. Or the fourth effect is it can go scattering, that is, in between this you may have red blood cells. So these red blood cells will get this ultrasound and it will scatter around. So these are the four interactions that can occur when you send the ultrasound to the tissue. So first is the reflection. So compare the ultrasound beam reflection as to a light reflection which we have studied in physics in our plus 2 and all. So the reflection will depend on the acoustic impedance of the subject on which it is thing and the angle of reflection. So if it is coming at 90 degrees, that is the optimum, that is immediately it will reflect back. That is why we have to keep it perpendicular to the tissue. But if you're sending it at an angle, it will not reflect back into the probe. So an angle of 90 degrees is optimal for echo. Then the scattering RBC will cause scattering because the radius of the RBC is smaller than the wavelength of the ultrasound signal. And Doppler works on this principle of scattering. That is, the RBCs will scatter these images, and based on this only the Doppler is working. So the scattering depends on the particle size, the number of particles, that is RBC size, the number of RBCs, the transducer frequency, and the compressibility of blood cells in plasma. That is called the hematocrit. Patient is dehydrated, that also will affect the Doppler. And the principle of with scattering only we use Doppler, as well as we use the speckle tracking in with tissues also. We use with the scattering mechanism, because this ultrasound will scatter into the within the tissues, and these will come out as small speckles, and we can track these speckles to track the motion of the myocardium. So refraction, that is, there is no reflection, but it refracts after changing a different angle, just like the concave or the convex lens. So the importance of refraction when considering echo is that these refracted waves will go and strike another tissue, and that will reflect. So we can get a double image artifact or when doing an echo. So getting an artifact that is double mirror image artifacts, it is because of this refraction. Attenuation, that is where the ultrasound signal ultimately decreases in its intensity and ultimately dies off. So it depends on attenuation coefficient of the tissue, the transducer frequency, distance from transducer, and ultrasound power. Coming to resolution. So resolution is the ability to distinguish two different points clearly. So I'll explain resolution by these two pictures. That is, this is an image with a good resolution. Here the resolution is low, so you're not able to distinguish two different points clearly. So that's a simple image. So considering echo, there are various types of resolution. That is, we have the spatial resolution as well as the temporal resolution. Spatial resolution is in the three dimension, in the axial and the lateral. The axial is the Z axis and the lateral is X and Y axis. So in all these planes, how much the resolution is, that is what we call the spatial resolution. And this generally denotes the static image resolution actually. So, but when it is moving, the spatial resolution when it's moving or the structure is moving, and the resolution we get with that moving structure, then we call that as temporal resolution. So in echocardiography, we generally say a resolution like more temporal resolution we are attaining, and the temporal resolution we express as frames per second. So resolution, these are the main three types: the axial resolution and the lateral resolution, and these are the parameters that will affect the axial resolution. That is the pulses, that is pulse repetition frequency of the scan line, and the lateral resolution, scan line or the frame. Temporal resolution will depend on the frames per second, and the frames per second is typically when we use this computer monitor and all, we say the monitor of this thing is 60 hertz or 70 hertz. What it means is, if the resolution of the computer monitor is 60 hertz, it means that the in image in 1 second it will change 60 times. So that is how we mean 60 hertz. 60 times it's changing in 1 second. So temporal, the word temporal means in relating to time. So that is for moving structures we call it as the temporal resolution. This is a picture showing the axial resolution as well as the lateral resolution. Just skipping these slides, not that, but just we have to understand the concept of temporal resolution. That's it. So axial resolution, side by side lateral resolution, and temporal resolution is it's a moving structure. And these are the parameters that will affect each of these resolutions. So our temporal resolution will be affected by depth, the sweeping angle, line density, and the pulse repetition frequency.